Welcome to our first episode of 2023 that we will talk about the periradicular surgery. We do the surgery when the teeth has a persistent periradicular pathosis that did not respond to the non-surgical approaches. As for the endo specialty, it was recognized in 1963 after the introduction of safe, effective local anesthesia. So doing this surgical root canal treatment is mostly done by endodontists. Endodontists that they do it in a range of 70-80% of all the cases. General dentists, they perform 15% of the treatment, and other specialties do the surgical root canal treatment in 60% only. Let's talk about the etiology. Why did this periradicular disease became persistent? Why did not respond to our non-surgical retreatment? We know that the microorganisms are sealed in the root system. They can be found in the dentinal tubules, in the canal irregularities, like the deltas, the isthmus areas. So if you have a good seal that we prevent any leakage of these microorganisms to reach the periradicular area, we will get the healing. When this does not happen, we will get what is called the persistent periradicular disease that needs other approaches that are surgical to get the healing and to eliminate these microorganisms in reaching the periradicular area. So as we said, that overextension of the filling is worse than short filling, because we now have a root that is continuous between the root canal and the periradicular area, which means that the microorganisms now have an open route to reach this area and cause the periradicular infection. Also, decrease in the immune system of the host gives these opportunistic microorganisms the opportunity to increase their virulence and to cause this disease. After all the development in doing the surgical treatment, it did not become the last choice. In some cases, it can be our first choice of treatment. For example, when we have long posts of irretrievable separated instruments, for example, if we have non-negotiable ledges, canal blockage, transportations, hard cement fillings material, all of these, and of course the failure of the non-surgical treatment, make the surgical approach our first choice. Also, talking about the economically, the endodontic microsurgery may be the most cost-effective option for the management in comparison to the non-surgical retreatment or the extraction and placement of an implant. Because, for example, when the patient does not want to replace their crown and their restorative material, and also we can know now after the development that happened, the prognosis and the success rate of the surgical treatment has the same percentage as the implant retention, that is in the range of 90%. Here we have the success rate of the surgical root canal treatment is 90%, and the implant is also in this range. So we must take in perspective all the possible treatment options. For example, here we have to take in perspective the bone quality, the practitioner's skills, the systemic disease, for example, the periodontal support, the quality of the coronal restorations. All of these aspects must be taken in our judgment in doing the appropriate treatment. For example, now after studying all the possible treatment options, we have decided that the surgical root canal treatment is our option of treatment. So what do we do? What are the steps of doing this procedure? Before we start talking about the surgical root canal treatment, I found it interesting to know how the healing occurs when we do the surgical when we do a wound, for example, after extraction of a whole tooth or after doing the resection of the apical part of the tooth. What happens on the biological aspect? First of all, after the blood vessel contracts, which is initiated by the serotonin that is secreted from the platelets degranulation. After that, the permeability of the vessel increases, allowing a protein-rich exudate to enter the wound side to form the first initial clot that is non-organized and has serum exudate, erythrocytes, tissue debris, but it is the first step in initiating the other steps the other steps of healing. So it is advised that we compress over the surgical flap with an ice gauze to minimize the thickness of the fibrin clot and accelerate the wound healing. The second step is when the neutrophils emerge to the site, and these they enter the wound and reaches their after 6 hours of the clot formation, and they increases in number to reach the peak after 24 to 48 hours after the injury. Their role is by the wound decontamination, which means that they phagocytoses the bacteria. After that, they decrease in the number after the macrophages reaches the site of the wound, and this happens in the third or the fourth day when they reach their peak concentration. The macrophage lifespan is longer than the neutrophils, and they stay for a longer time in the wound until the healing is complete. Then they initiate the formation of the granulation tissue, which is an important step in getting the soft tissue healing. So the fibroblast now and the endothelial cells have the primary role in the formation of the granulation tissue. So what do? The fibroblasts secrete collagen, which is first detected in the wound at the third day of the injury. These collagen fibers become organized by cross-linking, which is different from the first fibrin clot that we discussed earlier. So in granulation tissue is composed of a matrix of fibrin, glycosamine glycans, endothelial cells, and the new capillaries. These form the initiation cell of regeneration of the structures. For the endothelial healing, the epithelial healing starts by the formation of an epithelial seal on the surface of the fibrin clot. This process begins at the edge of the wound. Migration stops as a result of contact inhibition of the epithelial cells from the opposing wound edges. Once the epithelium from both sides of the wound is in contact, an epithelial seal is achieved. When I think it's obvious that the growth becomes from both sides, and when they reach to the sides at reach to each other, they give a signal that the wound is healed, and there is no need to further do growth of the epithelial growth, so they stop. What about the heart tissue healing? The beginning of the clot formation and the inflammatory process is the same as the soft tissue, but the difference is the maturation phase, which is recognized by the presence of osteoclast and the osteoblast. The osteoclast debride the necrotic bone from the wound margin. As for the osteoblasts, they produce the bone matrix. They secrete a collagen-rich ground substance that is essential for the mineralization. The osteoblasts also cause calcium and phosphorus to precipitate from the blood. So what is the mechanism of the mineralization? The hydroxyapatite crystals are formed in vesicle units inside the membrane of the osteoblasts. So a membrane surrounding this vesicle unites with the other membrane, forming the outer wall of the cell. And then they enlarge and eventually rupture. This process begins with the deposition and growth of hydroxyapatite crystals in the pore regions. For the cementoblast formation, the cementum formation happens by the secretion of special cells that are called the cementoblasts. The formation of cementum is important because it makes the wound resistant to the resorption. The start of the formation begins after 10 to 12 days after the surgery, until we have a full coverage that happens after 28 days. There is no need to stop the anticoagulant medications before doing the endodontic surgery. Now let's talk about the steps of doing this procedure. First of all, we must study the case probably using the best radiograph that we have until now, which is the Cbct, to take the perspective about the lesion site, its orientation, size, relation to adjacent structures, and to know the best incision site that we should get, what are the tooth involved in our procedure. So this Cbct is important, and as we said before, we take a small field of view. The whole procedure, which is the time, it only takes 2 to 5 seconds of the exposure time, which is the actual exposure time, but the scan time overall takes from 10 to 40 seconds. That's all. After that, we take an informed consent from the patient that he is fully understanding the benefits, the risks, and other treatment options before we start the procedure. It is advisable to give a medication of a non-steroidal inflammatory drug before initiating the surgery in 30 minutes to enhance the postoperative analgesia, which is we give an ibuprofen 400 milligram dosage. There is no need to give prophylactic antibiotics before the periradicular surgery. Only, however, for immune-compromised patients, for diabetic patients, and for higher risk surgeries like the orthodontic surgery, we can give the prophylactic antibiotics that will give actually good results of decreasing any inflammation, any infection, operative infection that may happen. Also, we advise that the patient do a mouth rinse of 𝐏𝐿 before we start doing the incision, and this routine he must be doing it before 1 to 2 days of the surgery by doing a 30-minute rinse twice a day. It is also advisable that the patient has with him an assistant getting with him to the clinic, and we can give a low dosage of a diazepam drug for a more relaxed patient and less stressful surgical experience. These are the equipments that we use. We can see the difference in the size regarding to the place that we are working with. These are the retractors. These are the bloggers that we we plug the MTA inside the wound. This is a syringe for the MTA. This is another type, and this is a hard plastic block that we do the mixing of the material until we get it to a wet sand consistency. Then we drag it into this notch. It is called. Then we use these syringes to get the material and to plug it in place. We must, of course, have an assistant with us when we are walking. What about the anesthesia? What is the most the effective anesthetic regime that we must do for the surgery? Infiltration of the surgical site with a local anesthetic containing 1/50,000 epinephrine is the technique of choice to obtain vasoconstriction and hemostasis. The local anesthesia is first slowly deposited in the buccal root apex area of the alveolar mucosa at the surgical site and extended into 2 or 3 teeth on either side of the site. Also, we do a palatal or lingual infiltration. We can give. We must wait 10 minutes before doing the first incision. We can give a supplementary one cartridge after we finish the surgery to get a long-acting local anesthetic effect. This is beneficial in the mandibular arch more than the maxilla. Before initiation the procedure, we must ask if the anesthetic soft tissue anesthetic signs like numbness, and we can test it by a sharp explorer. Our incision must be on an intact bone with a vertical rather than an angled releasing incision to harmless vessels. We can use what is called the papillary base incision with one vertical releasing incision, which does not include the papilla, especially if the site is aesthetically important. So we do not include the papilla to prevent any possibility of recession of the papilla resection after getting the flap sutured. This is the triangular flap that we know that has only one incision, releasing incision. We retract the flap using a retractor. This is what is called the 𝐏𝐚𝐭𝐡𝐰𝐚𝐲𝐬. This name is a flap that starts from the attached gingiva. So we first measure the free gingival sulcus to know its depth. Then we start the incision from the attached gingiva and go above. When we do this type of incision, the shape of it is a rectangular type of flap. The flap that we make, it has the periosteum and the superficial tissue. So it is a full flap, and we do the releasing of it from the starting vertically from the releasing incision, doing it slowly until we get it to the other direction. Now, to remove the hard tissue, we use a surgical handpiece that has a rear air exit using a round burr to remove the osseous tissue and reach the apex of the infected tooth. Now, when we reach the granuloma or the cyst that we have, and we need to do an incision to extract it, or here they are saying that an idea that an inflammatory periradicular lesion is similar to the healing granulation tissue. So if you remove most of this irritant and did not do a complete curate of the periradicular tissue, because it is close to important structure, the vascular tissue or the neural tissue, the body can do a complete healing. After that, they're saying that it is important to remove all the infected tissue to get a clear vision of the site that we are working with. So I don't know what is the appropriate approach, but this is the idea that they are discussing here. After doing removing the periradicular tissue, now we must do the root canal treatment, and the root end recession. Before doing this, we must have a good working site. So we must use one of the localized hemostasis methods. We can use a collagen-based material like the 𝐏𝐚𝐭𝐡, which is an animal-based collagen absorbable material. It can cause some allergic response, but it does not interfere with the healing. It is a bit hard to deal with because it attaches to the equipment and the bone, but it gives a good hemostatic effect. We can also use these, which are called the cotton pellets, that are embedded with epinephrine, that gives a local hemostatic effect. The 𝐏𝐚𝐭𝐡 mechanism is that the collagen products help achieve homeostasis by stimulation of the platelet adhesion and initiation of the coagulant factors. We have also the gel foam, which is the gelatin-based sponge that is insoluble in water. It is biologically resorbable, and it can It can it promotes the platelet disintegration and the releasing of a thromboplastin and thrombin. The gel foam decreases the rate of healing if they are left in the surgical site and causes a foreign body reaction at 8 days. After that, it is this reaction is transitory and does not impair long-term bone healing. There's another substance that is called the calcium sulfate. It has been used as a substitute bone graft material to fill the bone defect since the late 18th. So, it is as a hemostatic agent. Calcium sulfate acts as a physical barrier. The material is placed in the bony crypt, allowed to set, and then partly carved away to allow access to the root end. The remaining material lines the crypt's walls, preventing the bleeding. So this is why it's called a physical barrier. When the root end filling has been placed and all end filling material is removed, the residual calcium sulfate can be removed or left in the place of surgical treatment of the surgical site. And the epinephrine pellets that we talked about, these they are frequently used at the hemorrhage during the oral surgery. It bonds to some material and causes a powerful vasoconstricting effect, so they provide a good hemostatic in the periradicular surgery. We must count how many pellets we have used to ensure that we remove any cotton pellets that are left before we close the site, and we must also make sure that no cotton fibers is intact attached to the wound to prevent any inflammatory reaction and reduce the healing rate. So there is a question: does using this high concentration of epinephrine do any cardiovascular effect? Has any cardiovascular effect, especially for patients who have some issues in their vascular system? They're saying that there was no change on the blood pressure and the pulse compared with the saline saturated pellet controls. So their effect is localized and there is no systematic effect that is harmful to the patient. What about using a cautery or the electrosurgery? It was the tissue was destructed and there was delaying in the healing compared to the other surgical sites without the electrosurgery exposure. So it is considered an extensive procedure. The aim of the endosurgical treatment is to create an environment that is conducive to the regeneration of the periodontium, which means that we are helping the body to by removing this irritant that is suppressing the healing. So after we remove this source of infection, the body now is capable of regenerating the periodontal tissues and get the healing of the site as before. So we must also prevent the recontamination of the periradicular tissue and prevent any failure that can happen in the future. But how much do we need to recede from the end of the root? It is a 3 millimeter is enough to include all the periphery canals and to get a healing. For example, here a 3 millimeter was capable of reaching the isthmus that was connecting the MB1 and the MB2 in the mesial root of a maxillary first molar. What about the angle of the resection? Nowadays we use a 90-degree vertical resection angle. We found that it gave more benefits than the previously used 45-degree angle, and that also gave a success rate, but it has some problems. Also, before amalgam was used as a retrograde material of a filling material, but now after the development we have in the equipment and in the material, we use a vertical recession. Why do we do it? Because here they are saying that it makes a stress forces to be evenly distributed and reduce the propagation of an apical fracture and provide a better environment for the apical healing. They are saying that we decrease the number of the dentinal tubules, that the opening of them, and increase their communication with the decrease their communication with the periradicular region to increase the healing. We do this recession, the root end recession, using a multi-fluid carbide finishing burr or a multi-purpose burr, or we can use an ultrasonic tips. So after we do the recession, now we do what is called the root end conditioning, which means that we use remove the smear layer that removes the mineralized dentine and exposes the collagen matrix, which enhances the adherence of the cells and increases the cellular growth and attachment. We can use the EDTA, the citric acid, and the tetracycline. The citric acid and the tetracycline have low pH, which means they are acidic and they can cause irritants to the periradicular space. As for the EDTA, it is pH is natural to an alkaline base. So it is the most the appropriate type of conditioning material that we use. Now we do what is called the retrograde preparation of the canal by using ultrasonic tips. We must ensure that we are inside the canal and we do not change the canal access. Here they are saying that we must use the ultrasonic tips when we are doing the preparation in low speed and with water coolant to prevent any possible fracture that we may face. The ultrasonic tips, they can be diamond or zircon coated, or they can be stainless steel. Here the author is saying that the diamond burr has a more cutting efficiency, and it makes the procedure faster and takes less time. So it is more preferable, although it causes more of a debris and a smear layer compared to the stainless steel that the cut of it is cleaner. Here we have an ultrasonic tip that has an irrigation port within it. We can do some adjustment in the shape of the root end to make it an oval shape, that when we add the root material, it fits probably, and we get a dome-shaped root end that gives us the best seal and stress distribution. What about the root filling material? We will talk about them briefly without getting in details. The zinc oxides, what we must know that the root end filling material must be, to say that this root end material is appropriate, it must be non-resorbable, biocompatible, dimensionally stable over time, and it induces the regeneration of the periradicular periodontal ligament complex. As for zinc oxide eugenol, it is soluble in water, it undergoes hydrolysis, it has a degree of cytotoxicity, so it is not recommended. For the intermediate, for the zinc oxide that is hardened with the resin, it is better than amalgam, but it does not induce the regenerative capacity of a hard tissue development. Here they are mentioning glass ionomer, some resin types of material like the diakite. It has some cytotoxic nature. The retroblast, which is dual cure. The geriocyte store. They have what is the thing about the resin substances, that they are sensitive to the contamination with blood. This contamination decreases the monomer transformation and causes leakage. So they are, and also they have some degree of some toxicity. The MTA is the most used material now because it has its biomechanical properties are superior. It does not it's not affected by the presence of blood. The leakage is so minimal. It hardens really well, and we know that there are stages of its hardening, starting as a powder, then a gel, then it solidifies and to becomes a hard structure of crystals. We know that it has a antimicrobial effect and a biocompatible material. We know that it has a longest setting time, which is 2 hours. It is a base, an alkaline. It induces the cementoblast cells to produce hard tissues, so they can attach to it. MTA gave 89% of clinical success. Bioceramics, which are relatively new and promising, like the endosequence root repair, They have a biocompatibility and antimicrobial activity similar to the MTA. They are composed of calcium silicates, monobasic calcium phosphate, and zirconium oxide. They are hydrophilic, radio-opaque, and high pH. They can have two types, the putty and the syringeable paste. It is preferable that we do the filling in a dry culture environment, in a dry environment. So we dry it first before we do the plugging of the MTA to the space. After we finish the we finish the surgical procedure, before we doing the suturing, we must take a radiograph to ensure that there is no foreign objects adhering to the flap, and to confirm the depth, the density, and the root end filling. Some bleeding is encouraged at this point, because the blood clot forms the initial subsequent healing and repair step. We first start with the corners, and we suture them with a single suture. Then we can do a continuous suturing, or we can do by one individual suture until we reach the end of the flap to close it. Then we use an ice gauze to and press on the flap for 5 minutes to make to provide stability to the fibrin clot, and to support the hemostasis. The patient should sit in an upright position for approximately 15 minutes. Then we give the patient a written instruction, post-operative instructions. Let's read them fast with each other. First, on the first 24 hours, the patient must use an ice pack on the site of the surgery. The patient must take all the medications that are prescribed, the antibiotics and the non-inflammatory drugs. They must do a clean wash twice a day, by a chlorhexidine mouthwash, without getting the brush or a paste to the site of the surgical site. The patient must know that there can have a blood that will change the color of the saliva for the first couple of days. It is if the bleeding is in its normal range, there's nothing to get worried about. But if it continued and it exceeds the normal range, so the doctor must be informed. And the patient might have signs of infection, like a sudden increase in pain and swelling, a feverish feeling, a sore in the glands of the neck area. So he must take 2 to 3 days of post-operative relaxing days. They must avoid the cigarettes, because it decreases the healing of the soft tissue. Soft diet is recommended to prevent any suture damage and possible bleeding. After a week, the patient must see the doctor to remove the sutures. We use a 5 zeros suture string, silk typed, which is non-resorbable. The resorbable sutures are not recommended. How do we deal with complications, which is the bleeding that may happen after the surgical treatment? Most bleeding can be controlled by applying steady pressure for 20 to 30 minutes, typically with a piece of moist cotton gauze or a tea bag. Bleeding that persists requires attention by the clinician. We can use an anesthetic 1/50,000 epinephrine as a first step of controlling the bleeding. We can use a cauterization by a heat source, which we normally use in the warm obturation techniques. Also, we can use one of the local hemostatic agents that we discussed before. The patient must not use a moist heat to the area, and only heat is applied after 24 hours. In the initial 24 hours, we use cold gauzes. The patient must be informed that there will be that they may experience swelling or change in the color of the skin, and it will eventually goes after a week or two, so there is no need to panic. At the end, the author is discussing that the GTR membrane and the bony graft. There, he's saying that when we have a great bone loss due to the periradicular cyst or infection or granuloma, then when we do the surgery, some epithelial cells may migrate to the site of the bone and decrease the healing of the site, decreasing the prognosis of our treatment and delaying the healing by forming this pocket. The basic principle of guided tissue and bone regeneration is that different types of cell repopulate a wound at different rates during the healing. The soft tissue cells are considerably more motile than the hard tissue cells. Therefore, they tend to migrate into the wound more quickly during healing. A barrier interposed between the gingival tissue and the exposed root surfaces and supporting alveolar bone prevents the colonization of the exposed root surface by gingival cells. This encourages selective repopulation of the root surface by the periodontal cells. The use of an absorbable barrier theoretically would allow periodontal ligament cells and other cells with osteogenic potential to repopulate the defect, resulting in a new connective tissue attachment and bone formulation. After a study of 12 months of surgery, the sites with the membrane had healed more quickly and the quality of the regenerated bone was superior. So, GTR should be considered as an adjunct to periradicular surgery in cases of apicomarginal defects. The patient must be informed by the additional costs and the origin of these membranes, also the additional procedure, time and stages. Two types of membranes. The resorbable membranes are superior because they're for our endodontic surgery, because they prevent any additional surgical opening to remove the membrane. The membrane can be made of collagen, polylactic acid, laminar bone, and this membrane, to prevent its collapse, it must sit on a bone graft. The bone graft materials can be an graft, autogenous graft from the same patient, an allograft from a human patient but not the same one, the xenograft from an bovine, or a synthetic graft like the hydroxyapatite grafts. When we said before that when we close the tissue, we must do a pressure on it, but here when we add the graft, we should not do any compression to the site. We must ensure that there's a total tissue coverage of the membrane by the flap. That's it for our for the intentional replantation. It is recommended for the mandibular second molar when the site of it is a bit hard for doing the surgical root canal treatment. Also, the buccal bone in this area is thick. So we do the intentional replantation, which means that we extract the tooth and we keep it in a saline gauze and do the retrograde endo treatment. Then we redo the replantation of the tooth. After we do it, we apply a pressure to the tooth to ensure that it is in its socket, and we ask the patient to bite on a cotton pellet to apply force to the tooth. And this is a case that showed success when we did this this procedure. So the reimplantation is recommended for the second mandibular molar. That's a wrap. See you soon. Bye. Periradicular surgery success rate has reached 90%. Periradicular surgery is done when non-surgical retreatment fails, or tooth has unretrieved broken files, highly calcified canals, difficult ledges, isthmus, and apical delta. The process of soft tissue wound healing starts by the clot formation, which begins with blood vessel contraction when it is initiated by platelets degranulation of serotonin. Permeability of the vessels increases, allowing a protein-rich exudate to enter the wound site, and a clot is formed. As a result of production of chemoattractants by the various compounds of the clot, polymorphinocular neutrophils begin to enter the wound site within 6 hours of clot stabilization. The PNNs is wound decontamination by means of phagocytosis of bacteria. About the time the PNM's population is declining, which is 48 to 96 hours after the injury, the macrophages begin to enter the wound site. Macrophages have a much longer lifespan than the PNMs. They remain in the wound until healing is complete, promoting the formation of the granulation tissue. The fibroblasts and the endothelial cells have a primary role in the formation of the granulation tissue. As this network of collagen fibers is let down, endothelial and smooth muscle cells begin to migrate into the wound. Subsequently, as wound healing progresses, the collagen fibers become organized by cross-linking. A major difference between soft and hard tissue wound healing is found in the role of the osteoclast. Functionally, osteoclasts act as organizational units to debride necrotic bone from the wound margin. As for osteoblasts, they produce the bone matrix. They secrete a collagen-rich ground substance that is essential for mineralization. Osteoblasts also cause calcium and phosphorus to precipitate from the blood. During regeneration of the periradicular tissues, cementum forms over the surface of surgically resected root ends. Cementogenesis is important because cementum is relatively resistant to resorption. We start the process by studying the case using a Cbct image. Then we take informed consent issue specific to surgery. The patient must be thoroughly advised of the benefits, risks, and the other treatment options and must be given an opportunity to ask questions. No need to stop anticoagulant medications before the surgery. Infiltration of the surgical site with a local anesthetic containing 1/50,000 epinephrine is the technique of choice to obtain the vasoconstriction and hemostasis. After the injection of anesthesia, the surgeon should wait at least 10 minutes before making the first incision. We opened a triangular flap, doing vertical incision on intact bone. For anterior opening, we can start the incision beyond the papilla and free gingiva, starting the incision with the attached gingiva. The surgical handpiece with 45-degree angle head and rear air exhaust and using a rounded burr to make the opening of the bone for the treatment. Extract the lesion with burrs or ultrasonic tips. Then we use gel foam, cotton pellets impregnated with epinephrine, calcium sulfate to control the bleeding and clear sight of the vision. We cut 3 mm of tooth and using metal or ultrasonic burrs in 90 degrees cut. Then we prepare the surface using a data. We prepare the root canal using ultrasonic diamond tips. We mixed MTA to a wet sand consistency and we plug it in the canal. We close the flap and do the suture using a 0.056 string. Then we apply pressure to the wound with cold 𝐏𝐻𝐿 to control the bleeding and enhance the clot formation. When bone defect is present in site, GTR material and bone graft can be used, and we ensure that the whole flap covers the GTR membrane. We give the patient the instructions of 2-day relaxation and that a systemic fever may happen with pain and swell in the site. The patient must take the prescribed antibiotics and anti-inflammatory drugs and to use a cold 𝐏𝐻𝐿 at first 24 hours of the surgery. For the management of a surgical complication, the bleeding can be controlled by applying a steady pressure for 20 to 30 minutes, typically with a piece of moist cotton gauze or a tea bag. Bleeding that persists requires attention by the clinician. Pressure to the area and injection of a local anesthetic containing 1/50,000 epinephrine are reasonable first steps. Cauterization may be performed with a heat source commonly used for warm obturation techniques, or local hemostatic agents may be also used that are thoroughly explained in the episode before.